All right, so this is chapter 14, and it's the end of life, death, dying, grief, and loss. Not a fun topic, but we've got to address it. So, death's a normal part of life, and we can't cure every illness, right? There are certain illnesses that they can take people out. And all of us as human beings, forget about nurses, have to deal with the death of a loved one at some point. And we have to deal with the fact that we're going to die. We're the only creatures that live with the knowledge that we are mortal, that we're going to die. So at some point in your career, even if you haven't done it yet, you probably will find yourself taking care of someone who's dying. And when that happens, you have to confront your feelings and think about how you feel about the dying process and about death itself, whether it's a religious belief, a spiritual belief, whatever your personal thoughts are, but you have to reconcile them so that you can be strong for the patient. Imagine if the hospice nurse is taking care of the dying patient and the hospice nurse is bawling her eyes out. How scared will that patient be? Think about it, right? So you have to keep it together. And if you know that that's not something that you're good with dealing with, then plan accordingly and don't go work for hospice, right? It's natural to be scared and it's natural to have anxiety about it. Nobody likes to think about death. But, at some point we have to talk about it, right? Approaching death. How do we know? I've had a million patients say, how much longer, how much time, how much time? I always tell them, I don't know the exact time frame. I can usually give you kind of a window, though, based on what I see when I assess the patient, right? So what does the patient that's dying look like? They're going to usually have a decreased level of consciousness. Either it's stuporous or obtunded, just kind of out of it. Sometimes they'll have the labored breathing, that Cheyne-Stokes respirations, and that is the crescendo of a shallow respiration, like, and then apnea. And at some point when they have that period of apnea, the breathing won't start back up again. The death rattle, that's something that people call, it's like a gurgling. And we have medications that we can give. For example, atropine, which is an anticholinergic, and it's usually a cardiac med, but atropine ophthalmic drops we can put under the tongue, believe it or not. So eye drops under the tongue, and it dries up the secretions and diminishes that death rattle, because that is uncomfortable for people to listen to. It's scary, right? Their ability to move and touch is diminished, but they can still feel, hold their hand, talk to them, even if you're not sure if they can hear you. I always would do that. I would always hold their hand and talk to them. The mucus, like I said, that collects in the airways, but the atropine will help with that. Usually they're incontinent of bowel and bladder, if they even have anything left in their bowel and bladder. It depends on what the disease process has been. Usually people will stop eating and stop drinking, and that's one big sign that the end is coming. Mottling and cyanosis. Mottling, and I included some pictures in here. Circulation slows down, and what you'll see is splotchy areas on the skin. That's called mottling. Usually starts at the periphery, so the feet, the hands, and like forearms and the lower legs. You'll start to see this mottling. Sometimes they'll be cyanotic. You'll see perioral cyanosis, like blue around the lips. You'll have no reactivity if you shine a light in their pupils. It's like the light's on, but no one's quite home. Their pulse is usually slow and weak. Blood pressure is usually very low. Sometimes you can't even get a blood pressure. And frankly, when nurses try to get a blood pressure on a dying patient, the question is why? Right? Why? We already know what's going on. Why would you even bother doing that? Extremities will start to get cool. Sometimes they'll be clammy, right? Sometimes, not always. And they're not swallowing at this point. So these are all things that you can kind of see. When a person stops eating, you can go without food for 7 days, even a little more than that, really. But you can't go without water. So if you're going without anything at all to drink for more than 2 to 3 days, you're not going to be around very much longer, okay? So that is what mottling looks like at its worst. That's, a foot and a leg of someone you see how it's like splotchiness right? I'm going to pull some more pictures and add them to this, but I thought that was a good one for you to see. And this speaks to post-mortem changes. When the patient does expire, especially with hospice at home, it's a respect thing. We clean the body, and we've had patients. I know who was the one that said about a sweater that they're cold? Maybe it was the night class. That a family member said, oh, she's going to be cold when you take her out of the house. Can you put a sweater on her? Just put the sweater on her. Right. That's someone who's still kind of trying to process that death. So we have to be kind. All right. The one thing too, the jaw. Oftentimes what will happen, the jaw will hang open and it'll get rigor. Okay. So before rigor mortis sets in, you want to try to get the jaw closed and close the eyes. And make sure you pull the covers up. Like if they want to say their final goodbyes in the house, and people often do, especially if they're not having a viewing. Pull the covers up, make sure the head is elevated, because the minute the person dies, circulation ceases. When that happens, gravity will make the blood pool whatever the lowest point of the body is. And so when the blood pools like that, that's you don't want the family to see that, because that's kind of frightening. Changes in mental activity, changes in sleep patterns. These are the earlier signs. Right. All right, let's get back. We had a little bit of an interruption for a second, but no biggie. Let's go back to that PowerPoint. Okay, there we are. And yeah, we talked about all this stuff, the sleep patterns. Most of the time, they're just sleeping, right? Just sleeping. If they have pain, manage their pain. And you're looking for nonverbal signs of pain in addition to verbal signs, right? Don't let anyone suffer. One of the things that I see in hospice a lot too, family members will say, oh, I don't want her, I don't want her snowed with morphine. So if you had a choice to be awake and alert and in agony, or be medicated and be comfortable, what would you pick? Medicated, right? And sometimes we have to have a really lengthy conversation with the family to make sure that they understand that. If someone's actively dying, do you want their last moments on this earth to be painful? No, of course not. No. So pain management's important. And in hospice, we use Roxanol, which is morphine sulfate. It's liquid. It's a concentrate. Quick in, quick out, under the tongue. And that works wonderfully. Okay. So now let's talk about the different types of loss, right? And these are things that you probably will see in ATI, these kinds of questions. So, and make sure you know these, okay? Necessary loss. A necessary loss is something that is part of life, right? We know it's coming, but it still can be painful, right? I usually say necessary loss and maturational loss are kind of the same. As parents, we have kids. We raise our kids. And the whole point of raising kids is to say, okay, now they're going to go out into the world and do their own thing as people, right? So they have to go, right? Maybe not too far, but they have to go. And for a lot of people, they have that empty nest syndrome and get very upset when children leave, right? So, but it's expected, right? If you're doing your job as a parent, you're doing a good job. Your goal is to make a good adult, right? So they're going to leave and they're going to go to school and they're going to have a family, hopefully, and all those good things. So that type of loss is expected, but some people have a hard time with it, okay? Actual loss, just like the name implies. You've actually lost something, and it doesn't have to be a human. It could be a pet. It could be a body part, right? It could even be a job for some people. So you've actually lost something, and there's a grieving process most of the time, right? A perceived loss. Loss is something that you feel that you've lost, but really it's not something tangible that other people can identify. So it's something in your head, like maybe in your mind, you've lost your freedom, right? because of a relationship that you're in, but other people can't necessarily see it, but in your mind, you see it. That's a perceived loss. We talked about the maturational or developmental loss, and that's things that are expected to happen as we grow, that it shouldn't be a surprise, right? Okay. Situational loss. I use like tornadoes, hurricanes, a flood, that kind of thing, where, you're fine, and then all of a sudden, boom, you're homeless, right? That's a loss. And anticipatory loss or anticipatory grieving. When you expect, if you know that someone's ill and you know that they're dying, you, in your head, prepare yourself, but you can only prepare yourself so much. It still will change when that person actually passes, okay? So make sure you understand those different types of loss. Okay, so what's hospice? What's palliative care? The word palliative or palliation means to relieve symptoms, right? So if somebody's in pain, we palliate their pain. Hospice is palliative, but not curative at all. So in other words, if you're on hospice, that means that there's nothing that anyone can do about whatever disease you have, whether it's end-stage heart failure or stage 4 cancer, whatever it is. Palliative care, sometimes people will still try, maybe surgery for debulking of a tumor. That can be palliative or curative, right? So with palliative care, they can still have procedures done and things like that. With hospice, it's, we're going to keep them comfortable in different ways, but we're not going to do things that are invasive to a patient, okay? And, the caregiver, when you have hospice at home, particularly, I always would ask whoever the caregiver was, because we focus on the client, but I would always say to the caregiver, how are you? How are you holding up? How are you making out through all this? Do you want to talk? What can I do to help you? Because that is not easy to sit there and watch somebody you care about die in front of your face. Not easy. So normal grief. Now we're going to talk about the different kinds of grief. What's normal? I hate the word normal, right? So it's considered uncomplicated grief. When there's a loss, people get sad, okay? How long can people grieve? There's no time frame associated with it, right? So it's different for everybody. But what I will say is that when 6 months have gone by and they're still having trouble coping with it, that sometimes they need to talk to somebody. Maybe it's becoming complicated grief. When you lose I lost my mother in 2001, and it was a sudden thing, but it gets easier over time, but you never forget it, if that makes any sense. But time does make it a little easier, It always hurts initially. People during a grieving period, you don't realize this, even with normal grief, can have chest pain, headaches, chronic fatigue, all kinds of somatic symptoms, physical symptoms people can have because of grief. There's even something called Takotsubo syndrome. If you've ever heard of somebody dying of a broken heart, right? That's a thing. It's a real thing. When someone is in such anguish and grief, you see this a lot with people that are married like 50 years, 60 years, right? And the one partner dies. The other one dies 6 months or less later sometimes. That's broken heart syndrome. So it's dilated cardiomyopathy that comes from extreme stress and anguish, right? Everything gets tight, right? And it makes the left ventricle get bigger than it should be. And then it's heart failure. It's a form of heart failure. Now we have complicated grief, okay? And complicated grief, there are different types of complicated grief. It can be chronic, it can be exaggerated, it can be delayed. Sometimes people are in shock and you look at them and you're like, they don't look sad. They're not crying or anything. What's going on? Sometimes it just hasn't hit them yet and it takes a minute. So the best thing that you can do for people is just be there for them, right? Whatever they need, be there for them. With complicated grief, it's prolonged, right? It usually takes longer. Sometimes you need to get professionals involved, psychotherapy or whatever, to talk to them. People sometimes are so grieving that they can't go to work. Some people can't get out of bed. It becomes a clinical depression situation, right? And it can last for an indefinite period of time. That's why it's important. If you notice something like this, they've got to get some help, someone to talk to. Anticipatory grief, like we talked about, if you know that someone, my daughter-in-law's dad has stage 4 pancreatic cancer, so we know it's coming. Nobody knows exactly when it's coming, but we know it's coming. So you kind of start in your head going, all right, I got to prepare myself for this, right? It never really works 100%, but at least, a little bit. You start the grieving process before they're actually dead. Disenfranchised grief, okay? So if somebody killed themselves, somebody overdosed, it's something where you've lost someone and it's in an not socially acceptable way, right? So if someone committed suicide, oftentimes people are not as empathetic or compassionate to the family members that are remaining, which isn't right, but it happens. So you have to keep in mind that loss is loss. Right. So if someone killed themselves, even people that have miscarriages now, with miscarriages, they have bereavement programs. So they will actually have a funeral service for the baby, depending on how many weeks of gestation the mom was. But for abortion, I love this whole pro-life and pro-choice thing. I mean, when people have an abortion, it's usually not just willy-nilly. It's usually a lot of thought that goes behind having an abortion. And it's a loss, whether they realize it or not. It is. And we have to be compassionate about that. That's a hard choice to make, but sometimes it's the choice that has to be made, So that's disenfranchised grief, that sometimes you'll find that certain types of loss, society maybe doesn't look at as empathetically or sympathetically as they should, right? Okay. All right. Is the following question true or false? The greatest challenge for all healthcare providers when a client is dying is to confront their own personal feelings about death and dying. If you said true, you were right. That's a big deal. Like I said, I've had nurses where they're in the patient's home and they are bawling, crying, like sobbing. You cannot do that. When all is said and done, you will get in your car and then you will cry. And that's fine. And you're human and it's okay. But you can't do it in front of the family or in front of the patient, because imagine what you're doing to them. You're going to scare the heck out of them, right? And again, always ask the family, how are you doing? How are you coping through this, right? Because different family members, you're going to have different responses. I see the best and I see the worst in people. I saw two brothers fighting over a boat in the yard of the patient while he was dying in the bedroom. And he was still alive. He wasn't dead yet. And they were screaming and cursing at each other in the yard over who gets the boat. I mean, that's insane, So that's the worst. And then you see sometimes the best in people. That gives you hope for mankind, where people actually act right, End of life discussions. You want to make sure the family knows what to expect, right? Because you'll have family make her eat. We have to feed her. We have to feed her. No, you don't want to do that, because then the patient could aspirate. When they stop eating for a reason. It's time, And here's where advanced directives are really important, right? So that everybody, including your family and your healthcare provider, knows, what do you want? What do you not want? What's important to you? Is it quality or quantity of life? And what do you want us to do for you or not do for you, right? Children. I had a woman in her 30s with ovarian cancer that had a 10-year-old and a 12-year-old. That was probably one of the toughest cases. Because it's, to explain death to children, depending on the child's age, is very hard. Young children don't understand the finality of it. They think, oh, she's going away, but she'll be back. Older children can sometimes, especially boys, no offense to any males in here, but sometimes it's hard for boys to show emotion. So they kind of clam up. And that's not healthy either, because now they're holding all that stuff inside, and that can manifest as anger. And that's not healthy, right? So you want to make sure that you're trying to address every family member where they are in the developmental process, right? And then culture and ethical beliefs or ethnic beliefs, they come in play too. Catholics, last rites before you're dead. Very important to Catholics. Like if you don't get the last rites, you're not going to get into heaven, I guess. We talked about Islam. They want to be facing east. They want to be facing Mecca. Orthodox Jewish people, oftentimes the family member will say, no, don't touch the body. I'll clean it. And that's okay to let them do it. Just make sure you take all the tubes and stuff out, right? They don't want that on them. Pain relief, I already talked about that. I can't tell you how important that is. Keep them comfortable. People say, well, morphine makes you die quicker. It does not. It does not. We don't euthanize people. That's still murder. Still illegal, last time I checked. Morphine, we give morphine to somebody to keep them comfortable. And if they have something like end-stage heart failure, you will see a respiratory rate in the 50s or 60s, which is like, it looks like this. That's not comfortable, is it? So, you need to give them morphine because morphine, the side effect of the respiratory depression, slows the respiratory rate down. And that's important. We want that slowed down because you're not comfortable if you're gasping for air, right? Finances. I've had people where a family member passes and they have no funeral arrangements and no money. So I have actively worked all night to find like crematoriums that will do it for like the bare minimum. And also in the state of New Jersey, Medicaid does have a stipend. So if you're on Medicaid, if you qualify for that, they will give you a stipend towards it. But I don't know if anybody knows this, but a funeral, like a whole funeral with a casket and a viewing and all that good stuff, can cost upwards of $10,000. It's a lot of money, right? They can burn me in the backyard with the leaves. I mean, I say that all the time. So for real. I mean, I'll be dead, so it won't matter, you know? But the point is that it can be very costly and it can be a really big burden to families. There are crematoriums. There's one, and I don't want to say it because then I guess it would be an endorsement, but it starts with an A and it's in central New Jersey and they only charge $150. And after like 27,000 phone calls, I found them. And that was a big relief for the family. And we all took a collection and paid for it because they had no money. But these are all things that people are thinking about, coupled in with the grief. So now not only are you brokenhearted, but you're like, I don't know how I'm paying for this. So there are lots of things to consider when you're dealing with a family member and a client that this client's passing, okay? Just remember, be sympathetic. Is the following statement true or false? A common source of conflict for the healthcare team and family members is the use of narcotics to help control the dying individual's pain. Absolutely, it's true. I have had nurses get on the phone with me and say, I'm not comfortable giving morphine. How's your patient? Are they comfortable? This is what you have to think about. And unless the doctor ordered something that seems ridiculous, then of course you would question it. But remember about tolerance too. When someone is dying, they will have a tolerance built up quick, right? So you may start out with literally a quarter milliliter, which is like a half a milligram of morphine. And people, oh my God, it's morphine. It's less than a Percocet. Right. And that's the way I explain it to families. Have you ever taken a Percocet or a Vicodin when you went to the dentist? This is less than that, equivocally. So, that sometimes will help people understand it's not what they think it is. People hear the word morphine and it makes them crazy. Morphine, you're going to kill. No, we don't kill people. And then Kubler-Ross, Elizabeth Kubler-Ross, she's a theorist and she came up with stages of grief and loss, and you need to know these. And I remember it by saying DABDA, right? DABDA. So first, let's talk about grief and loss. So grief is the pain that people feel, when they lose somebody. And the loss can include grief, but it doesn't have to be death. Loss can be an amputation, like we talked about, different types of losses, okay? And so these stages, DABDA, denial. Oftentimes when people get the news that they have, say cancer, stage 4 cancer, and we've exhausted all of our treatments, I'm fine. Or the family will say, no, we're going to keep fighting. You can only fight if it's a reasonable expectation that the fight will achieve something, right? And sadly, there are instances where if somebody's got metastasis everywhere, there's nothing that we can do. And I know it's horrible news, but it's the truth. Then anger. Sometimes people will feel anger. And remember, these things are not necessarily in this order. It can be in different orders for different people. But these stages have been identified. Most people go through. They're angry. Why? Why did this happen? Why did it happen to him? You know, that's normal. Bargaining, especially I see this, sometimes with religious people. Please God, I'll be good. I won't do XYZ anymore if you just let him live, or, those kinds of things, trying to make deals, bargains with themselves or with God or whatever, right? Depression, when it sets in that this is really happening, people, are usually depressed. And it's not the same as clinical depression, right? So this depression is a normal human emotion when something hard happens. So it's not, it's not something out of the ordinary. We have emotions and sometimes we're sad, right? So sadness is an expected emotion if somebody you care about is dying, right? And then the last but not least is acceptance. So saying to yourself, listen, there's nothing I'm going to do. I have to move forward after this. I'm going to get past it. I'm going to work through it. I'm going to be okay. Right. So, like I said, and not in that order necessarily, but I'm going to move this here and put that there. So make sure you know Kubler-Ross. And one more question and then we're done. When the client diagnosed with a terminal illness holds the healthcare team responsible for the situation, what stage of dealing with death is the client experiencing? It's your fault. You're a terrible doctor. You did this. It's a couple, right? Isn't it a couple? It's anger, it's denial, right? Okay. And you see that a lot. I'm suing the hospital. Sometimes when there's no reason to sue the hospital, or they don't sue the hospital when there is reason to sue the hospital, right? You see both sides of it. So, anger is the big one. People, why? Why is this happening? Right? It's a normal emotion. They just have to work through it. All right. So that is it for this one. Not a happy topic, but until next time, I am going to be out of here.